Sejam bem-vindos ao podcast Physio Frontiers. Essa é uma série especial do portal Fisiortopedia em parceria com a base de dados Pedro Brasil.
O objetivo desse podcast é contribuir para aproximar pesquisa e prática clínica em diferentes contextos, quebrando barreiras linguísticas e trazendo convidados internacionais que fazem a diferença na área.
Eu sou o Bruno Saragiotto.
E eu sou a Tia Yamato.
E juntos nós iremos te guiar nessa jornada pelo mundo.
Prepare-se
e vem com a gente! Fala pessoal, tudo bem? Bem-vindos a mais um episódio do nosso Physio Frontiers podcast da fisioterapia que quebra barreiras internacionais dentro da fisioterapia. O episódio de hoje eu conversei com a Arianne Verhagen. Ela é a chefe do departamento de fisioterapia da Universidade de Tecnologia de Sydney. Ela é uma fisioterapeuta com muitos anos de formação, é uma fisioterapeuta holandesa e ela hoje trabalha na Austrália, então ela contou para a gente um pouquinho, né, esse início de carreira, como ela acabou indo para lá, como ela escolheu a pesquisa. Ela trabalha muito com revisões temáticas, então a gente conversou um pouquinho como é que o clínico ele pode consumir melhor revisões temáticas, o que ele pode fazer, que ferramentas ele pode utilizar para ler uma revisão temática. A gente também falou sobre estudos de acurácia diagnóstica, né, de testes de palpação, testes específicos, né, testes funcionais, o que está faltando nessa área, né, como é que a gente, né, diminui esse gap da pesquisa com a prática. Falamos também de carreira, né, desafios, sendo uma pesquisadora, né, mulher, mãe, né, de 2 filhos. A gente falou também um pouquinho sobre, né, como ela vê as novas gerações de fisioterapeutas, então acho que ficou um papo bem legal, bem bacana para vocês. Então fiquem agora com o episódio completo. É isso aí. See you soon. Hello, welcome to another episode of the Physio Frontiers podcast. I'm alone today. I don't have Tia with me, but I'm very well accompanied by Professor Arianne Verhagen. She's the head of the physiotherapy department of the University of Technology, Sydney, in Australia. She's very well known by her systematic reviews, Cochrane reviews, diagnostic accuracy studies, and many, many other studies in the musculoskeletal area. Welcome, Arianne. It's a pleasure talking to you.
Yeah, nice seeing you.
Yeah. So you've been to Brazil recently, I think 1 or 2 months ago. Yeah, it was great having you here. Did you enjoy?
I really enjoy Brazil, yes. People are... Yeah.
That's great. So I'm going to start from the beginning. So why did you decide to be a physiotherapist?
When I was at high school, I didn't know what to do. And I followed all kind of preparations of different courses at university, because my parents wanted me to go to university and not to a technical university. And but finally I met a friend, and she was studying physio, and I had a kind of introduction to medicine, and I didn't like that because the introduction was full of cutting cow eyes and mice and what have you. So I thought, oh no, that's not my thing.
Too much blood.
And the friend said blood and details and what have you, and that's not my thing. And then the friend was studying physio, and she was very enthusiastic. And then I thought, wow, that sounds nice. I had to convince my parents because they really wanted me to have a university degree, but well, you go where you go if you're passionate about things you do. And I really enjoyed becoming a physio. I never regretted to have not studied medicine, although I must say that when I worked with GPs, I thought, whoa, that would be a nice thing also, being a GP. But yeah, you have to follow the whole course of medicine with a lot of blood and things like that. That's not my thing.
Yeah, for me it was kind of a similar story. But how research came to your life? How did you end up making research, going to master's degree?
Oh, when I finished my physio degree, I become a physio in a private practice, which is very common in the Netherlands. So you do primary care. And then I got 2 children, and I was, because of the pregnancies were very heavy, I was a bit physically disabled. So I came home on Friday very, very tired physically, but definitely not tired mentally. And I thought, this is not a good combination, because physically it's exhausting me, the whole being a physio, but mentally I'm not even awake. So I thought I need to go back to uni to do a master course to get more mental challenges. And then by coincidence, I was 10, 12 years in clinical practice. So by coincidence, Rob de Bie started a master course of clinical epidemiology in Maastricht for physios. And I thought, well, that sounds good. That sounds something for me. And I never expected to go into research because research sounds boring. And I thought, well, whatever. But when you have a master course, that I'll see and what I do then. And but I really enjoyed it. It was a small master course with 20 students, 19 physios, and 1 chiropractor. And that was really fun. I really enjoyed it, and because we were the first cohort, and I actually found it very challenging and I liked it a lot to write. I know one of the assessments was that they made up a kind of, and they deleted the discussion section and they asked us to do the discussion, and we had 4 weeks to do that, and I find that very nice to do and very challenging. I got a high distinction on this assessment, and I thought, I think writing is something for me, and I think critically thinking is something. I really enjoyed that. So I gradually went into, and when I got my degree with honor, then I was asked to become a PhD, and I thought, whoa, no, I'm not going to do that.
It's a big step.
It is, well, yeah, it is, and especially because I had 2 little kids, that I was thinking I might do a job that is a bit better paid. But yeah, well, in the end, I like the people, and I thought, why not? Why not? And I just told them, if I don't like it within 6 months, I quit. And they said, well, that's fine. And I liked it. So I finished it. Yeah.
No, that's nice. Because my perception is that when you go to a research path, usually you had a good supervisor, you had a good experience in a honors or a master, then you go to a PhD. And if you have good experience, you increase your chances of being successful as a researcher and enjoying research. Because I think that was my case, and that's everybody that I talk about it's and tell me they have a good relationship with the supervisor. It's usually they follow a good path. Yeah.
I had no clue what the topic of the PhD was about. They got internal funding for something, and they had a very nice title, and I thought, I don't understand a word of the title. But in the end, I thought, well, I like the people to work with. Let's trust them. They're doing the right thing. So it all was just luck or coincidence that happened. So by coincidence, I had very nice supervisors, but also supervisors on top of the methodology that was developing within the Cochrane, for instance. So I was just very lucky being there at the right time, at the right moment, and just saying yes to something that I didn't know what it was.
Yeah, luck and hard working, probably. That's interesting. Yeah, and well, some people listening, maybe they don't know you're from the Netherlands. Now you live and work in Australia. And like, when did you move to Australia, and how was it? Why did you move? And yeah, you took a position as a head of the discipline, because people sometimes they think people who change country, they do because they are from a low or middle income country with less opportunities. But it's not your case from the Netherlands, and being already recognized as a researcher, a leader researcher in the Netherlands. So can you tell us a little bit about the background story of your move?
Yeah. Well, it is a long story. It covers about over 20 years. But when I was a PhD, one of the first conferences I was able to go to was the Cochrane conference in Adelaide, and then my family came over after the conference to Sydney, and we had a 3-week camping trip. But in between the conference and when they came over to Sydney, I had 5 days, And because I had 4 posters or 2 posters and 2 presentations, I said my supervisor said, well, we will pay you the internal flights in the domestic flights in Australia. And I thought I will go to Alice Springs. I will go to see the rock, the Uluru, and Ayers Rock at that moment called, but it's Uluru. And I went there and I fell completely in love with the outback. And I came back, and when we had a holiday with the kids, I said to my husband, you need to come. We need to go back to Australia. I want you to see what I find so really, really beautiful. And when we were 10 years later, I think, we were just planning to go back to Australia as a kind of sabbatical, or after we retired. And then 2 or 3 people in our family, friends environment died suddenly, age 40, 45, 48. And we thought, we're not going to wait with our trip to Australia until retirement. We might not make it to retirement, so let's go now. So it took us 2 years of arranging kids from school, unpaid leave from work, whatever. And then we came back to Australia. We did a round trip.
No. For a year?
No, for 3 months.
For 3 months. Oh.
And then my husband also fell in love with the outback and Australia itself.
Yeah, it's easy to fall in love with Australia or the outback.
Yeah, it is. And then suddenly I got a headhunter 5 or 7 years later in the email asking me whether I would be interested in a position in Curtin University in Perth. And then that didn't go well. That whole interview didn't go well. But my husband got used to the idea, well, we might have a future there, to have a bit of a couple of years of working over there. Sounds nice. When she makes sure she gets a job, I will be happy to join. And that's how it went. And finally, UTS came, and they were very persuasive. So they invited me for a week over, and they gave me all kind of a nice hotel and dinners and what have you, and explained all the lot. And I thought, this is a nice challenge for the last little bit of my career, because I was having a good job in the Netherlands and I was enjoying it and it was fun, but it was what it was. And I was going to stay there until retirement. And I thought, well, why not try something different? Just to keep your brain moving, just not to slowly graduate to retirement, but do something fun.
Yeah, and your children are not kids anymore, so it was
no, they're grown-ups.
Yeah, good moment.
Yeah, and now in their 30s, they not really like it that I went, but I said, listen, this is I'm an adult, I'm not old, so I will make sure you not have to visit me in a nursing home over there. But they both came over once, so and I hope they will come over another time again before we might decide go back to the Netherlands again.
All right, yeah, that's a nice story. I was actually personally curious about that. And Australia is really beautiful. I spent 1 month in the outback doing some volunteering work for I study, and was in Aboriginal kids, and it was amazing.
I know that. That's the Jane Latimer project, wasn't it? Yeah, I was also there for a week. And made it was very impressive. But
that was amazing. All right, let's move on with another topic that I want to talk about too, is about systematic reviews, because you work a lot with systematic reviews. I do too. And I do think it's a very important design for clinicians to consume, especially now, depending on the search you do. You find so many trials, and maybe they've been not informative enough, and you go to a systematic review. For me, it's still the best evidence. But at the same time, there's a lot of rubbish in reviews, networking meta-analysis, and I feel clinicians sometimes they are lost, especially with the networking meta-analysis. So do you have any tip for clinicians to read systematic reviews? I would say just choose a Cochrane review, but if you have anything in mind, like to help.
Yeah, but I think Cochrane reviews can be very difficult to understand for clinicians also. then they have to read
They're
the plain
huge.
language.
Yeah.
Yeah, they're often huge, and if you only read the abstract, sometimes there's a lot of data and a lot of jargon that makes it difficult. I think not to advertise my Delphi list, but I think these Delphi list or these quality assessment or risk of bias assessment tools, not the recent one of Cochrane, but the smaller ones like the Pedro scale. That Pedro scale, by the way, is based on my Delphi scale list. So they are comparable. This is a 9 to 10 item list that is a kind of reading guide. So if you, that's a reading guide of a randomized clinical trial, but if you can find these elements back in a systematic review, and you have these reading guides also for systematic reviews, like the MSTAR or the ROBIS guides. If you use these quality assessment lists as a reading guide, then it helps you understand what is important and what's not. But just critical clinical thinker, does this make sense? Does the table make sense? Things like that. And one of the basic recommendations I always give to students here is when a systematic review is done by 2 or 3 authors, just disregard it, because it's not a job you can do with 2 or 3 people properly. So
I agree.
just disregard systematic review if it's done by 2 or 3 authors. That's not enough.
Yeah. Yeah, also like the infographics or some strategies to facilitate interpretation, because if you have forest plot, when you use to, it's easy. But even if you're familiar, you have a Cochrane review with a forest plot and they are showing standardized mean difference, sometimes the clinician could be lost with that. And and actually Cochrane does a lot of materials there with plain language for clinicians that they can go there to study. And and I like the idea of using Amstar or Rob's tool. I think after a while you get used to. It's like the Pedro scale. If you have in your mind, you read a clinical trial, you can identify the main bias.
And if you use that as a reading guide, is this mentioned? Is that mentioned?
Yeah.
And if it's not, then it's not a good study.
Yeah. Are you still part of Cochrane group?
Yeah, I'm part of the diagnostic method still as a reviewer. I have been on the editorial board for a year or 3, and I'm part of the neck and back review group as a reviewer.
Right. Yeah, Cochrane. I think Cochrane is still the best standard, but as you said, it's sometimes too big, and and you need all the other forms to show. Even social media.
Well, it became very massive because the early Cochrane colloquium, there was a small group of 200, 300 people, and I could understand things easily. But when I now go to a Cochrane conference, it's becoming massive, and the statistics is becoming impressive, and all the tools you can use to make a review is impressive. So I understand people can get lost.
And I think in the near future you can automate most of the job in a systematic review. Then you may have 2 or 3 authors for a review if you do all with AI and algorithms.
There are some downsides to AI, I'm afraid, and you need a content expert, you need a statistical expert, you need a review expert, you need a couple of expertises in the.
That's true. Right. Just moving on, talk a little bit about diagnostic accuracy research, because recently in the past 4 or 5 years I've been doing few studies on that, and the more I study, more I think that I should have known when I was a physio student, and I didn't, and I have to learn afterwards. And so important for clinicians to use these concepts, actually, like the SNOUT, spin rules, the understanding predictive values, or even likelihood ratios. Do you have any ideas for brainstorming? What should we do to improve this gap between especially diagnostic accuracy research and clinical practice? If you need more training for clinicians, or should write it better?
Well, first, I think a lot of things need to be done better. we have now 2 student projects that we look at how the procedures is of straight leg raising and the upper limb tension test, for instance. And when you see these papers, that the upper limb tension test, no 2 papers do it the same way. And I think we might get some clinicians together and see, can we develop a kind of standardized way of doing these tests? Because if it's not standardized, how can you assess accuracy or reliability if it's not a standardized test? If you don't describe clearly when a test is positive, or if you vary between studies when a test is positive, then how can you think that in research it will become accurate or reliable? So I think we need to start from scratch as a discipline to look at the clinical tests, like this, the physical examination test, to see if we can standardize it and if we can, before we going out and test it. And I think one of the main things is that we also have to look what the accuracy and predictive value, that's more important actually, is of some of the history items, because we ignore in research massively the history taking exercise, which we all start our consultation with, which we all think is important, that we have a kind of grasp where the pain came from, when it was there, how it felt, what was the pain, numbing or something else. I think we have to start from scratch as a discipline. So I think we need to do that first before we go into the more fancy diagnostic systematic reviews, because they don't make sense to me. If you do a systematic review on the upper limb tension test, it doesn't make sense if you look at every study doing a test different.
Yeah. And well, coming back from scratch means like the university. I feel that, well, as a physio, I was trained in Brazil. Now I teach in Brazil, and I spent some time abroad. So I feel that here, a clinician, they don't have the background training they should have in the university. And now, although we have many videos, if you look for interpreting likelihood ratios or predictive values, you can find a lot of nice videos, easy explanations, editorials, easy read, but they just don't go there to find it, because it's not already in this background, in his ideas of, and I feel the same with use of prompts, or even the frames with the experience. I see that we use a lot in research, but I don't see much in clinical practice here in Brazil, particularly.
I think it's everywhere, Bruno, because why would a clinician use the Tampa scale to assess kinesiophobia if he doesn't know what to do with it? And it's 17 questions, and it's difficult to rank. There is no clear cutoff point for a reason, but there is no clear cut. Why would they do it? And we have been trying to work on decreasing these longer questionnaires into, is there one question that is as good as the whole questionnaire? I think we should do that more.
Yeah.
We should do that more often, but there are opportunities that you can do, that you can collapse the whole Tampa into one substitute question. I think we've done twice that kind of exercise. And I think that helps clinicians. If you do it that way, then they just have one question that they feel predicts a bit of the outcome. And if you can quantify how much it predicts or how much it can contribute to a kind of prediction rule, then that helps. At the moment, it's not very sexy for clinicians to use a lot of prompts, because they're time consuming, and in the end, they have no clue what to do with it.
Yeah, I agree. Okay, I have a question for you from my student, Renato Nietzsche, because I told him you'd be in the podcast, and he came up with this question. I'll read for you. He asked, many clinicians use palpation methods to identify body structures, and also to assess joint mobility as a diagnostic method for functional movements. And when you confront these clinicians with scientific articles showing that palpation methods maybe are not the best, or they're not good enough, they usually say that research cannot feel what my hands are feeling with my years of experience. So I think maybe he heard from someone, that's why he's asking. And he want to know how to teach these clinicians that many of the palpation methods are not good enough for diagnosis evaluation. I think it's similar to what we've been talking about, but just your thoughts on these palpation methods. And
my thoughts are clear. I think palpation methods with the aim of diagnosing something is not valid, but that's not why I would palpate people. I would still do palpation. I would still do a passive range of motion. I always like to feel people, but the information you get is twofold. First, the patient feels heard. So seen, heard, listened to, that if they don't have to undress, they always have a feeling this is not real. And that's not just for physios, it's also for GPs. So I learned from GPs that you're not doing these kind of things to do a real diagnosis, but to have a feeling, what kind of patient is this? Is this an anxious patient? Is this a patient that has a very low pain threshold, so everything hurts? Is this a patient that is anxious to move? Is this a patient that, well, whatever? You get an enormous amount of information by just touching people. And the physiotherapy profession allows you to touch people. A psychologist is not allowed to touch people, but you get a lot of information that helps you develop your treatment strategy. Because I'm pretty sure you recognize what I'm saying.
Yeah.
That it gives you another information. Don't think you do it for the diagnosis per se, but more for the kind of guidance on what can I do with these patients? What can I ask the patients to do? What can I expect the patients to do?
Okay, perfect. Yeah, completely agree. You see, Renato, keep doing the palpation for patient. Just don't use it for diagnosis. It's fine. All right. So I have just a couple more questions for you, Arianne. First one is come back talking about your career. Did you have any challenge in your career over the years, especially as a female and a mother researcher?
Cool. But I never had a career path. I know that Bart often asked me, what do you want to be in 5 years? I said, Bart, come on. I don't know. And I always go with the flow. I always go what time presents to me. And I really like methodological issues. So new methodologies I like prediction modeling, like prognostic modeling. This is new. Like diagnostic modeling, that's all new, and I like to investigate that. I like meta research kind of thing, so I like to follow that path just by my gut feeling. And now I'm at the end stage of my career. I feel I have an obligation to learn physios that research is fun and not boring, because I think that's also one of the things that clinicians don't go to research often because they feel it's boring. And so I try to show to people that it's fun. And I also like to help the junior researchers to get their academic career started, because I have been extremely lucky in my academic career by meeting the right people on the right time, having the right topics. I just fell into the whole development of the Cochrane collaboration and systematic reviews and things like that. And that's an ever evolving field, so it keeps my brain moving. That's one of the things that needs to be done. But yeah, I now try to spend my energy and time to educate people and to help them getting started. I think it's more difficult now to become an academic than it was 25 years ago.
Yeah, I think that's the thing I like most in research, that you are always with a new thing to think about, to learn, and you're always out of your comfort zone. So that's the thing I like it. And so you're the head of a physiotherapy course now since 2017, 18. Yeah. So from that 5-6 years, how do you see the next generation of physios? Are you making progress through the generations? What's your thoughts?
Well, I think looking back, a lot has changed already. When I started as a physio, I used TENS, ultrasound, traction, massage, a lot, these really passive kind of intervention, because that was the way to do it. And research and evidence-based medicine changed an awful lot in that field. So the physios at the moment are more, they don't use these electrical agents anymore, at least I hope. And they're more critically aware, I think, about what's happening. And I think if they just follow evidence-based medicine like they did for the last 25 years, then the field will evolve into a very valued and very valued profession within the health sector, which was not always the case 25 years ago, because the doctor and the surgeon was there, and then blah, 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 there, physio. But I think being involved in a lot of evidence-based medicine and being able to explain that and being able to express what you did and being a little bit more up to date with research gives you a more professional standard, that you can just have a good discussion with surgeons about the necessity of a surgery or something. And I think that will be the future.
Yeah, I think so. And I also feel that we used to be much more physical. Now we know more about psychosocial part of the rehabilitation, which is very important. Yeah. Okay, I think we're coming to the end of the episode. I have a final question for you, Arianne. So if you could get back in time and give some tips to young Arianne, what would you say? What pops in your head?
No, I'm not sure whether I have any advice to give, because I always followed my gut feeling, and that would be my advice. Follow your gut feeling and feel confident, and just don't be afraid.
And don't use TENS.
Sorry?
And don't use TENS.
Don't use TENS. I don't even know how these things work. The only assessment I failed was the electrical agent things. I forgot to plug them in. I forgot to turn them on. I forgot everything. So I'm not an electrical agent person, but I think follow your gut feelings and don't be afraid to take risks, because that it always turned out well for me, taking a risk or a challenge.
Yeah, perfect. All right, thank you, Arianne. Thanks so much for being here with us, and thank you for listening or watching. So see you soon. Bye bye.